Good morning. My name is John Sevransky. I'm the editor-in-chief of Critical Care Medicine, and we have a special edition of the July video here at FCCM headquarters. I am here with Kate Nugent, who is the co-chair of the FCCM MCCR course, and also the medical director of the Capacity Command Center at Emory. And in the July issue, we have the article, Geographic Clusters in Sepsis, Hospital Mortality and the Role of Targeted Regionalization by Moore and colleagues, that also has an accompanying editorial by David Wallace. So one of the reasons that I'm delighted that Dr. Nugent is here is that, as mentioned, she runs the Capacity Command Center at Emory. And I would like to ask her, what steps are necessary if you have a patient in one emergency room that needs to go to another hospital for desired or specialized care? How do you do that?
Great. Well, thanks for having me. I appreciate it. I think when we're thinking about kind of implementation of the Capacity Command Center at Emory, some of the things that we've found are most valuable when it comes from transferring a patient from an emergency department at one hospital to a more specialized operating unit really come down to about four things. The first is communication. Communication that's direct, communication that's closed loop, whether that's from our transfer center team to our transport team, whether it's from our referring facility to our accepting facility, and that closed loop kind of end of it becomes important. I think the second thing that's most important is collaboration and making sure that all the stakeholders involved in these patients' care are all on the same page and all have that same goal in mind of getting the patient again to the right place at the right time as fast as possible for the best care. Two other things that I think are important are prioritization. Ultimately, beds are not limitless, as much as we'd like to think they are sometimes. And being able to prioritize one service line, one patient over another, and knowing kind of how that looks in the grand scheme of things, I think is very important. And then finally, standardization of the process. That also ties back to a lot of communication, be it with short intakes from a referring facility, an early connection to our specialized care team to really kind of get the ball rolling. I think the other key piece of standardization is probably related to how transfer team members are coordinating with bed placement team members who then coordinate with our transport team.
Thank you, Kate. Many of our patients have time-sensitive conditions. Can you spend a moment talking about the logistical challenges of moving a patient from one emergency room to another hospital for the delivery of time-sensitive care?
So I think when it comes to time-sensitive care, I'll tie back to that initial kind of answer. And again, it kind of goes to communication and prioritization more than anything else. Whether that's a septic shock patient prioritized over an aortic dissection patient, whether that's notifying our transport team of what type of transport and what level is needed in order to ensure that, again, we're all on the same page, really become, I think, most important. Other challenges really relate to ensuring, again, that all stakeholders are on the same page and that not every patient is the priority of one or of several, but we understand kind of that flow of patients from one institution to another from a larger systems perspective.
Thank you, Dr. Nugent. So if you're interested in the topic of moving patients or transporting patients, I would encourage you to look at the July issue of Critical Care Medicine and the article Geographic Clusters in Sepsis, Hospital Mortality and the Role of Targeted Regionalization by Moore and colleagues. Thank you and have a good day.